Ever been there? Trying to get a stubborn kiddo to swallow their medicine. It can feel like, well, an Olympic sport sometimes.
Oh, absolutely. The pursed lips, the head shaking. Yeah, it's a familiar scene for parents and definitely for healthcare providers, too.
Well, today we're zeroing in on exactly that challenge. We're
Mhm.
taking a really comprehensive look at pediatric medication administration.
Exactly. And our guide for this is a really detailed chapter from Saunders Comprehensive Review for the NCLEX-PN Examination, 7th Ed. It's pretty much a cornerstone text in nursing education.
So our goal here is to pull out all the critical information you need to understand how we safely and, effectively give medications to children.
We're talking about the core nursing concepts, the safety protocols you absolutely have to know, the actual procedures.
Yeah, and even some assessment points, things you might not immediately think of. We'll also touch on handling different clinical situations and, importantly, look at some review questions from the chapter itself. It should help things stick.
Definitely. We're aiming for thorough, but, hopefully not overwhelming.
Right. So where did the chapter kick things off?
It starts right where it should, with oral medications. Because let's face it, that's how most kids get their medicine most of the time.
Makes sense. Pills can be tough for little ones, so it's often liquids and suspensions we're dealing with. But it's not just about spooning it in, is it?
No, not at all. Getting the dose absolutely right is, well, paramount. The chapter really stresses using things like oral plastic syringes or other devices specifically made for kids.
Ah, like those little calibrated spoons or droppers.
Exactly. Figure 38:1 in the text shows a few examples. Using the right tool is just crucial for accuracy. You can't guess.
And what about suspensions? The ones you need to shake up.
Yeah, with those, thorough mixing before you measure is non-negotiable. If it settles, the dose won't be right. Simple as that.
Okay.
And once you've measured it carefully, you need to give it pretty much immediately. Again, to make sure they get the full intended dose.
Okay, that makes total sense. So you've measured correctly. What about the actual technique of getting the child to take it? Any key tips there?
Yeah, the chapter gives some really practical advice. Positioning is a big one. You want the child upright, head slightly elevated.
To prevent aspiration.
Yeah.
Choking.
Exactly.
Especially if they get upset.
Yeah.
That simple step really minimizes the risk.
And for younger kids, the ones who might put up a bit of a fight.
There are specific holding techniques. For smaller children, like infants or toddlers, positioning them sideways on your lap can work well.
How so?
Well, you gently secure the arm closest to you behind your back, cradle their head, maybe hold their free hand. It gives you stability and can feel secure for them. Then administer the medicine slowly with the right device: spoon, cup, syringe.
Okay, what about older kids who might be okay with tablets or capsules?
If they can swallow them, great.
Huh.
But the chapter wisely advises checking their mouth afterwards. Make sure it actually went down.
Good point. Kids can be sneaky.
They can. And if swallowing is tough, some tablets can be crushed. You can mix them with a tiny bit of applesauce or something similar.
But not all tablets, right? There's a warning there. A critical one. You never crush enteric-coated or timed-release tablets. And don't open capsules unless you're specifically told to. It messes with how the drug is absorbed, its effectiveness, everything.
Okay, that's a huge safety point, really crucial. Now, the chapter also has box 38:1 with general guidelines. What are the highlights there?
These are really your foundational checks. It starts with the absolute basics. 2 patient identifiers. Every single time. Name, date of birth, whatever the policy is. Gotta have the right child.
Of course,
What else?
involving parents or caregivers. They know their child best, right? They often have the magic touch or know what approach works.
Absolutely. Their input is invaluable.
Then, allergy checks. Goes without saying, but always double check before giving anything.
Mm-hmm.
The guidelines also mention preferring liquid forms for younger kids, less choking risk. And an interesting tip for older kids: sometimes using a straw helps them swallow pills easier.
A straw. Huh. Never would have thought of that. Yeah, bypasses some of the tongue, maybe. It also warns against mixing meds with essential foods, like milk or their favorite cereal.
Why is that?
2 reasons, really. 1, if the med tastes bad, they might start refusing that food later in a virgin. 2, you can't be sure they'll eat or drink the whole thing, so they might not get the full dose.
Ah, okay. That makes a lot of sense. Anything else in that box?
Let's see. Oh yeah, using a straw can also help mask unpleasant tastes by directing the liquid past some taste buds. And offering a chaser-like juice or even a popsicle right after can help wash away the taste, makes the whole thing less awful.
Good practical tips.
It also mentions being aware of the medication itself, like acidic syrups might interact with certain things. And finally, a really important one, document what worked.
So the next nurse or caregiver knows the trick.
Exactly. Consistency helps everyone, especially the child. Makes future doses go smoother.
That's smart.
And one last point on oral meds, particularly for newborns and infants. Their liver and kidneys aren't fully developed yet.
Right, they process things differently.
They do. It means they might metabolize and eliminate drugs more slowly, so the effects can last longer, and you need to be extra careful with dosing and watching for side effects in that age group. It's a really critical physiological point.
Okay, super important to remember. Let's shift gears now to parenteral medications, injections, basically. Subcutaneous, intramuscular, intravenous. Where do we start?
Let's start with subcutaneous and intramuscular, or sub-Q and IM. For sub-Q, the chapter notes common meds like insulin, some vaccines. Sites are usually areas with decent fatty tissue, upper arm, abdomen, front of the thigh.
Okay. IM, AM, intramuscular seems like site selection would be even more critical there.
It absolutely is. You have to consider the child's age, how developed their muscles are, and crucially, the volume you're injecting.
So where's the best spot for, say, an infant?
For infants, the preferred site is the vastus lateralis muscle. That's the outer thigh muscle. Figure 38-2 shows it clearly. And table 38-1 is really useful. It gives maximum volumes you can safely inject into different muscles based on age. You have to follow those guidelines and your facility's policy.
Makes sense. What about needles? Size, length?
Generally, for pediatric sub-Q and IM, you're looking at needle lengths from about 1/2 inch to 1 inch. Gauges typically 22 to 25.
Okay.
There's a neat trick mentioned for estimating length. Gently grasp the muscle. About half the distance of that pinched tissue is a good estimate for needle length.
Oh, interesting.
And remember, pediatric doses for injections are often tiny, calculated to the nearest hundredth of a milliliter. So you'll usually use a tuberculin syringe for accuracy. Always check your agency's specific guidelines, though.
Right. Policy is key. Anything to make the injection experience a bit less scary for the child.
Well, sometimes just putting on a fun bandage afterwards, one with cartoons or something, can make a small difference, a little positive reinforcement.
Every little bit helps, I guess.
Yeah.
Okay, let's tackle intravenous medications now. IVs. This feels more complex.
It definitely has more layers. First big rule. IV meds for kids are always diluted before giving them.
Yes.
Always.
Diluted. Got it.
And because it's going straight into the vein, watching that IV site like a hawk is absolutely critical. You need to check for infiltration. That's where fluid leaks out into the tissue or any inflammation before, during, and after every single dose.
Constant vigilance. How are Phymeds typically given? Continuously.
They can be. Either as a continuous infusion through a primary 5E line, delivering a steady amount over time, or they can be given intermittently, several specific doses throughout the day.
Okay.
And the chapter really emphasizes this. The exact dilution, the infusion rate, all of that must follow the drug's specific instructions, the doctor's order, and your hospital or clinic's procedures. No shortcuts.
Right. What about flushing the IV line? Why do we do that?
Flushing is standard practice. It does two main things. Make sure the entire medication dose gets delivered into the vein, and it helps keep the IV catheter open, prevents clots from forming.
So you flush before and after the medication?
Yeah. Typically, yes.
Yeah.
You need to know your agency's specific procedure for the volume of saline to use it. Varies for peripheral versus central lines, and for different age groups. Usually it's somewhere between 3 and 20 milliliters.
And that flush volume counts towards their total fluids, right?
Absolutely critical point. You must document that flush volume and include it in their total intake calculation. The flush is usually given at the same rate as the medication itself.
Okay. The chapter digs a bit deeper into intermittent IVs too, doesn't it?
It does. A child getting intermittent meds might already have a primary IV fluid running, or they might just have an IV access port, sometimes called a saline lock or heparin lock.
So how does that change things?
Well, if there's a primary line running, the intermittent med is often given piggyback. It's infused through a secondary line that connects into the main one. If there's no primary fluid running, just the access port, the med can be given as an IV push, injected directly, usually slowly, or again, via piggyback into that port. But in these cases, you have to be super careful checking the instructions for dilution and how fast to infuse it.
And the saline flush still applies?
Every single time. Doesn't matter if it's push or piggyback, primary line, or just access.
No.
Precede and follow every intermittent dose with a normal saline flush.
Gotcha. And we use pumps for this usually?
Almost always in pediatrics, yes. Electronic infusion devices, pumps, or controllers are standard for regulating IV fluids and intermittent meds. They offer much greater precision and safety.
Okay. What about those special IV sets, burettes? I've seen those.
Ah, yes, burettes. They're really handy for giving small, precise volumes of medication, especially intermittently or piggyback.
How do they work?
They're basically microdrip sets, meaning they deliver tiny drops, usually 60 drops make 1 milliliter. They have a chamber, like a graduated cylinder, that holds maybe 100, 150 milliliter, marked in 1 mmol increments.
To mix the med right in there.
Exactly. You add the medication and the right amount of diluent directly into the burette chamber, and then you set the infusion rate. Labeling is crucial here. You need to clearly label what drug is in it, the total volume, and whether the med is infusing or if it's the flush going in.
Right. Clarity is key. And syringe pumps. How are they used for IV meds?
Syringe pumps are another way to deliver very precise, often small volumes. You draw the medication up into a regular syringe, place that syringe into the pump device,
Okay.
and the pump pushes the plunger at a very controlled, preset rate over the prescribed time. The pump tubing connects to the child's 5V line, usually via a Y connector. Great for meds needing slow, accurate delivery.
It sounds like fluid management is just constantly hovering over everything with pediatric IVs.
It is absolutely paramount. You have to meticulously track and document all fluid intake over 24 hours. That includes the main IV fluids, the medication volumes, and all those flush volumes.
Because overhydration is a real danger.
A significant risk, yes. Kids just can't handle fluid overload the way adults can. The maximum daily IV fluid amount is very specific to each child based on weight, condition, other factors. You always need to check the provider's specific orders and your facility guidelines.
Okay. Constant vigilance on fluids. Let's switch now to the calculations themselves. Body weight seems like the big one in PEDS dosing.
It's fundamental. Kids change size so rapidly, weight-based dosing is often the standard. Box 38-2 reminds us of the key conversions. 1 pound is 16 ounces, and 1 kilogram is 2.2 pounds. You'll be doing those conversions a lot.
And how are the dosages usually written in orders?
Typically, you'll see mg/kd day milligrams per kilogram per day, or maybe mg/ob day. Sometimes it's per dose, like mg/kg dose.
Okay.
And often that total daily dose, calculated by weight, is then divided into smaller doses given throughout the day, say every 6 hours or every 8 hours.
So what's the basic process for calculating it?
First step, make sure the child's weight is in the right unit, kilograms or pounds, to match the order. Then, calculate the total daily dose using the ordered amount per kilo or pound. Finally, if it's divided doses, divide that total daily amount by the number of doses per day. Box 38-3 also lists common abbreviations, which is handy.
Right. Now, besides weight, the chapter also talks about body surface area, BSA. Why use BSA?
BSA is another way to tailor doses, especially for certain drugs like chemotherapy agents. It takes both height and weight into account.
So it's maybe a more accurate measure of overall size than just weight.
Exactly. It gives a better reflection of metabolic mass, which influences how drugs are handled. Figure 38-3 shows the tool used to find BSA. It's called a nomogram.
Okay, I've seen those charts. They look a bit complex. How do you actually use one?
It looks intimidating, but it's straightforward once you do it. You find the child's height on the left scale, their weight on the right scale. Then you take a ruler or any straight edge and draw a line connecting those 2 points.
And where the line crosses in the middle.
That's it. Where your line intersects the middle column, the SA or surface area column, that's the child's BSA in square meters. M sub unseri. Box 38-4 walks through an example, and the chapter makes the point that kids the same age can vary hugely in size, which is why BSA can be more precise sometimes.
Okay, so once you have the BSA number, how do you calculate the dose?
Well, if the drug order is actually written as, say, milligrams per square meter, then it's simple multiplication. You just multiply the dose per square meter by the child's BSA that you just found. Box 38-5 shows an example of that.
Makes sense. What if you only have the adult dose information? Can you use BSA to estimate a child's dose?
Yes, there's a formula for that, shown in box 38-6. It basically compares the child's BSA to a standard average adult BSA, which is taken as 1.73 milliliters.
So it's like a ratio.
Pretty much. You calculate the child's dose as child's BSA 1.73 milliliters multiplied by the adult dose. They give you an estimated pediatric dose. It's useful if specific PEDS info isn't available, but it is an estimate. Always best to confirm if possible.
Okay. Good to know that exists. Now let's shift gears a bit. The chapter talks about developmental considerations. This feels huge, because you obviously can't treat a baby like a teenager when giving meds.
Absolutely not. Understanding where a child is developmentally is just crucial. It impacts how you explain things, how you approach them, how you comfort them. It makes the whole process safer and
Yeah.
hopefully less traumatic.
Right.
Your approach needs to be tailored. The chapter mentions some general strategies first, like being fully prepared before you go in, involving parents appropriately, figuring out comfort measures ahead of time, and just aiming for the best experience possible for the child.
And then box 38 tab and breaks it down by age group. Right. Let's quickly go through those. Infants.
Infants, keep it quick. Then immediate comfort holding, rocking, pacifier, simple, fast, comforting.
Toddlers.
They can be tricky.
Toddlers. Very brief, concrete explanation right before you do it. Expect maybe some resistance or crying, accept it within limits, provide an outlet if needed. Then immediate comfort hugs, toys, soothing voice.
Okay, preschoolers,
Yeah.
similar. Pretty similar. Short, simple explanation just before. Acknowledge their feelings. Offer comfort afterwards. Praise. A sticker, maybe letting them play with the syringe afterwards. Needle removed, of course.
School-age kids.
They understand more. Yeah, with school-agers, you can explain more why they need the medicine. Give them some control if possible, like choosing which arm or helping hold the bandage. Explore their feelings. Maybe use therapeutic play. Set clear expectations for behavior. It might sting a little, hold still. Distraction helps too. Teaching them how the med helps is good.
And finally, adolescents.
Adolescents. Treat them with respect. Give thorough explanations. Respect their privacy and desire for control. Explore their understanding of their illness. Encourage questions, self-expression. Involve them in decisions about timing or method where feasible.
Wow. It's so much more than just the mechanics, isn't it? It's really about understanding the whole child.
It really is.
Yeah.
Now, the chapter also includes a critical thinking question, which is a good scenario. It asks, the nurse is preparing to administer a medication that has an unpleasant taste to an infant. What should the nurse do to minimize this unpleasant effect?
Okay. And the answer, which is in the text.
Right, on page 483. The recommended approach is to draw the med into a needleless syringe, gently place the tip on the side of the infant's mouth, aiming towards the back of the tongue.
Kind of bypassing the main taste buds on the front.
Exactly. And then administer it slowly, letting the infant swallow naturally, makes it much more tolerable.
Good technique.
And then to really wrap things up and test understanding, the chapter has practice questions, numbers 386 through 390.
Right. Let's just quickly mention what they cover. Question 386 is about checking if a prescribed morphine dose is safe based on the child's weight. So, dosage safety calculation.
Yep. 387 is a straightforward calculation. Given an acetaminophen prescription and concentration, figure out the volume in milliliters per dose.
Okay. 388 is similar. Another calculation for phenobarbital, finding the volume needed.
389 adds a twist. The order is in grams, but the tablets are in milligrams. So, unit conversion first, then calculate the number of tablets.
Important step. And 390 uses that BSA formula we talked about. Given the adult dose and the child's BSA, calculate the estimated pediatric dose.
Exactly. And what's really great about these questions in the Saunders review is the rationales. They don't just give the answer.
They explain why, right?
Thoroughly. They often tell you the test-taking strategy, the cognitive level, client needs, nursing process step, content area, priority concepts. And crucially, for the math ones, they show the formula and every single step of the calculation.
That's so helpful for learning. Like for 386, the rationale would show how to figure out the safe morphine range for that specific weight so you can compare the ordered dose.
Precisely. And for 387 and 388, it spells out the formula. Dose ordered, dose on hand, X quantity, amount to administer, and walks you through plugging in the numbers.
And for 389, it highlights that essential first step. Convert grams to milligrams before you calculate tablets.
Right. And for 390, it clearly shows the BSA formula being applied. Child's BSA, 1.73 meters of body key, X adult dose equals child's dose, step by step.
So yeah, this has been a really comprehensive deep dive, covering pretty much everything from that chapter on pediatric meds, oral, parenteral sub-Q, IM, all the complexities of IVs.
The critical calculations using weight and BSA, those vital developmental approaches for different ages.
Administration techniques, tips for tricky situations like bad tastes, and even a look at how to tackle those practice questions and learn from the rationales.
So if you are looking for that thorough exploration of pediatric medication admin calculations based on a solid nursing resource, well, this was it. We've tried to hit all the key concepts, guidelines, procedures, safety points, priority actions, terminology.
Yeah, including those review questions and rationales, we can definitely say we've covered the breadth of what's in that chapter.
Which brings us to maybe a final thought for you, the listener. Considering everything we've discussed, the technical stuff like routes and doses, but also the communication, the developmental aspects, the psychology, what do you think is the single most crucial element for ensuring safe and effective medication administration to kids?
Hmm, that's a tough one. It all seems so interconnected.
It really is. And maybe that interconnectedness is the key takeaway. Reflecting on how all these pieces fit together is probably essential for providing the best, safest care.